This is the Primary Care First experience, a dedicated space for practices participating in primary care first to learn from each other and share ideas. Join us to hear inside stories and learn from experts in the field who, like you, work every day to innovate and advance primary care.
Welcome back to the Primary Care First Experience podcast. I'm your host, Christy Bowling-Demetz. Today we're talking with MedStar Health about their house call program and the ways they actively team to meet patients, families, and caregivers where they are. MedStar is a private health system serving Washington, D.C. and Maryland. While their model is based on home visits, there are many transferable concepts for clinic-based practices, including interdisciplinary teaming and collaborative care planning. We're joined today by Dr. Stephanie Bruce and Gretchen Nordstrom. Dr. Bruce is the Geriatric Medical Director of MedStar House Call Program and House Call's Physician of the Year in 2011. Gretchen, Chief Social Worker at MedStar, plays a pivotal role working with patients and caregivers to assess health-related social needs. The team is currently comprised of 4 nurse practitioners, 3 geriatricians, 3 social workers, and 4 office staff workers in addition to an office-based nurse. The MedStar team further extends to include community partners such as pharmacists and physical therapy. In this episode, you'll hear how the team works together to meet the medical and social needs of nearly 500 patients in their homes and how they're extending care plan visibility across care settings. Join us now for a great conversation with Dr. Bruce and Gretchen. Welcome, Dr. Bruce and Gretchen. I'm really looking forward to our conversation today regarding your work with patients and caregivers in the home and lived environment, really unique. Tell us more about yourselves and most importantly, why this approach is important to you.
I learned about house calls in my fellowship, but actually I had an older experience even as a medical student, seeing people in their home out of the VA home-based primary care program, and then following a primary care physician who just did house calls as a one-off, often as a hospital follow-up. So I think I had open eyes to just how powerful it is to see people in their own environment. What is the setup in their room? What is their risk of falls? What does it actually look like in their refrigerator? Who's in the home?
It's really great to hear that you've operated in a blended model as well as a more true house calls based model. Thanks again for joining us. And Gretchen?
I have always been interested in aging in place. It was just so perfect when there was an opening at the house call program because I got to work in the field that I was so passionate about, keeping people in the community for their medical care and for their living environment.
Talk to me about the patients that you serve and the population that you serve.
Most of our patients are in their 80s and 90s. Everyone is over the age of 65. Most of the patients that we care for are African Americans. About half are on Medicaid, and we have a large number of the patients we care for are, I would say, federal retirees. Many of our patients live in the typical DC row home. They're about 15, 20 stairs to get up to their house, which is, of course, a challenge. Many of our patients are living month to month on a fixed income, which is, of course, a challenge. What am I missing, Dr. Bruce?
I think you said it all. I think that physical environment, it was just resonating with me just to flesh it out. So we do have so many people with challenging physical environments that may or may not be supported by family. We also have a small cluster of patients who do live in more group settings, and most of our folks born in DC or the surrounding areas, or having moved up in their childhood. So many of our patients were part of the Great Migration where they or their parents moved up to the federal city to be government employees, as Gretchen mentioned.
How do patients and families find out about your model, your approach?
Word of mouth, always our number one referral source are families or friends. And then we do get referrals from other medical providers. We have a good reputation in the city, and people know that we provide good care, and so people just find out about us from their neighbors or from a cousin or whoever they're around. You have to call this program. Dr. Bruce took good care of my mom, and then they call up and become a patient.
Boy, when I think about primary care first and one of the quality gateway measures being patient experience, I think you just encapsulated right there. If they're willing to refer others on that they care about to you, that's a really strong statement. You should be proud of that.
I'll piggyback on that a little bit. I do have situations where 15 years ago we took care of a parent and now we're taking care of a daughter, or multiple siblings in a family in different homes. We work hard with our own home hospital emergency department to keep ourselves in there, and also with our home hospital social work department, that they know about us, but they're still not the vast majority of our referrals. So they know about us, they can refer if they identify a patient who really is floating out there without a good primary care physician. But to Gretchen's point, it's really word of mouth in the community that's our number one referral source always.
So switching a little bit to process, I'd love to hear, Dr. Bruce, from a clinical perspective, who's doing the home visits and how do you make those decisions?
So our baseline process is anytime we see a patient, we give them some idea of when we're going to come back. And on average, we see our patients about every 4 to 6 weeks, because that we've just learned over time, almost all our patients need that frequent kind of visit. If they need to be seen before that, that's where our frontline office staff is helpful. They call the office and they'll get them to the office nurse, or maybe directly to the nurse practitioner, who will do a phone assessment. And if they need to see them, we'll see the same day or the next day. So very open scheduling for urgent visits. Then in addition, if the office nurse identifies someone who might be sort of chronically unstable or needs more frequent visits, they'll send that information to the nurse practitioner. If the nurse practitioner feels like they need the physician in a little bit sooner than they were planning, they'll reach out to the physician and get us scheduled in. And in the absence of that, the physicians just see them periodically, about one every 3 to 4 visits. So about 3 to 4 times a year is a physician visit. So we rotate in that way. Then we also have our weekly team meeting where we identify anybody unstable. And sometimes coming out of that, we decide a patient needs to be seen earlier or needs a visit. And then when our patients leave the hospital, the physician, who's usually one of our own house call physician who's taking care of them, will again send a message to the nurse practitioner, and the nurse practitioner will get in there and see the patient within usually 48 or 72 hours. In a way, picture the nurse practitioner as the center of all these inputs of information, and then they figure out who needs to be seen.
And from a social work perspective, Gretchen, how does this all work?
The social workers, we attempt to assess all new patients coming into our program, either out in the home or over the phone, and at that time we'll determine whether or not are there ongoing needs, or is it just that one assessment and they don't need to be followed anymore. And then we also get referrals from the medical team, or sometimes the office staff even, if there's a social need that comes up in a visit, if they identify they need help with food or aid services, or something just isn't right in the home. Sometimes they'll ask us to just go out and do an assessment. And then sometimes we actually get referrals from patients or family members themselves. They'll call up and ask to speak to one of the social workers. We don't follow all of the patients because not all of the patients need social workers. We follow about 40% of our 500 patients.
Gretchen, what does that assessment look like?
It's an assessment that we created ourselves. Of course, it makes sure that they can afford different bills in their homes, such as their rent, their electricity, things like that. We assess the home, make sure that their home is safe, make referrals to those sort of supports if they don't have the supports in their home. A lot of questions about the supports for caring for themselves. So if they need help with their ADLs, making referrals to getting aid supports, those sort of things. It's not a long assessment, but it's a very thorough assessment. I always think of the medical care is how they come to us, but we try and address all those other aspects of their life, because we know social determinants of health are so important when it comes to medical care. And if you're not addressing them, you're not going to be able to meet the medical goals, because if they are concerned about paying something, they're not going to be worried about taking their blood pressure medicine. Or you're seeing someone in the office, you're not aware that their air conditioning is broken unless they happen to bring it up. So in our program, it's an easy message over to the social work team, and we're able to work on getting an air conditioner in the home so the patient doesn't end up in the hospital from dehydration.
Gretchen mentioned that we have great social workers, and we do. And I'd like to believe they're so great that they have managed over the years to educate a bit the rest of the team. So I think one of the things that you kind of learn when you work this closely as a team is there's a little bit of seeding across disciplines, which I think is only to the benefit of the patient. We do have the first clinician go in, at least put their toe in the water. So all our new patients also do get a couple brief questions about home safety, med management, and caregiver burden as part of a structured process. So sometimes that can kind of help and tee up the social worker who needs to be a higher priority. And of course, it works the other way around. Our social workers, when they're in there, sometimes see things that the patient didn't report to us at their last visit. And just with a flag away, we'll alert the medical team, even if you were here last week, hey, Mrs. Smith, I noticed is now complaining of X. Can you get back in there sooner rather than later? We're all sort of also feeding each other information across disciplines, which I think, again, is all to the benefit of the patient. It kind of keeps our eyes on them a little bit better.
You've shared some great examples of what feels like an incredibly seamless approach to the way you interact as a team, even though I know on any given day you're in multiple locations. It's not just a difference of two different practices, you're across the city. So how does that happen? It can't just be the EHR. There must be some other magic to that.
So I think the core of our connection really comes out of the team meeting, the weekly team meeting, because that's where at least we can see Zoom faces, and in better times, face-to-face, sit down and really have some interactions around patient. But in the real-time minute, it's all of the above. And I think the EHR is still the core of it. So something that just needs to be seen today, that's an EHR message. Something that probably needs to be seen immediately or within a couple hours, that's a more personal text message to a pager or a phone. Something that needs to be done right now, that's a phone call, direct person-to-person phone call in that moment.
How does that translate to, you've talked about your community partners and pharmacists, and how does the communication occur there that again, to the patient's perspective, feels like a unified team?
One of the things we do is some of those partners do actually also attend our team meeting. Right now, mostly just our home health partner. We don't currently have our pharmacists attend on a weekly basis, although they have in the past. So they're actually looped in that way. For me, I think the office team is also our point person for looping in all those other people. They often, if we need their help, they will help us reach out, the office coordinators and also the office nurse.
What about during the pandemic?
The social workers, we didn't go out into the home for a while. We learned how to support our patients over the phone. It was not the same. We certainly missed things. You can't look through people's mail and help find a document that you need for an application when you're doing it over the phone. The people who were a new relationship, it took a little bit longer to build that connection with them. And I want to say one of my first visits, I went out to someone who I thought had been pretty stable. I had to go out for to have her sign something, and I got into her little room that she stayed in, and I looked down and there's a big black hole on the ground next to her electric space heater, and I just looked at her. I was like, and it was May, and yes, her heater was on because she's 98 and she's freezing all the time. Huge safety concern. And I ordered her a new one right that day. Luckily, we had grant funds for it, and no one had noticed before because the medical team had been seeing her in a different bedroom. I happened to go to the back of the room and I saw it.
And Dr. Bruce, tell us more about your experiences during the pandemic.
Our first stage in COVID was always and foremost keeping our patients safe. So the first meetings we had when, for instance, our hospital started to shut down and was what do we need to do to make sure that we are not a vector bringing virus into the home. There was a 1 week period and then a 6 week period where we were doing largely televisits. And then shortly after that, we resumed routine house calls because we had enough personal protective equipment, we had protocols, and we had enough knowledge, we thought, to do that safely. But in that 6 week period, we didn't stop making house calls. So we limited it to what we considered emergency house calls. So that included anybody, again, unstable enough that they were thinking about coming to the hospital. We were actually doing more visits out there to see what we could get in the home to treat them and keep them out. We were also doing home-based testing as soon as it became available. So we had enough PPE to go in and test our patients who needed it for COVID. Once we had management protocols to help us, then we were doing more testing to help us get oxygen into the home early And eventually, when we got to that point, being able to provide home IV therapy with antibodies. So once those protocols came online. So kind of everything as we stepped up in the hospital, I like to believe in parallel, we stepped up in the home to provide care. And then I'll just say, brilliantly, finally last spring, February, March, and April, we also finally were able to vaccinate our patients in the home. So we had a whole nother protocol developed around bringing vaccines into patients at home. And that was some of the happiest work I did in 2021, as you can imagine.
Oh, I bet. Thanks for sharing that. What a journey it's been. I want to switch gears just a little bit and talk about care plans, because I know that's been an area of focus for you. But before we dive in, you and I have talked about this before. Care plan means a lot of different things to a lot of different people. So as I understand, you're working on how to document the care plans. And I'm gonna put a teaser to the rest of the conversation that listeners will be so excited about, and that you are looking at how to incorporate your care plans into the Health Information Exchange, which is CRISP for Maryland and DC. So first, start by describing for us what the care plan looks like for you and your patients.
So for me, and I think for the team, the care plan is everything that the patient needs help with and everything the team is going to bring to them to provide that help. What we've done in the past existed somewhere in the minds of the care team and the minds of the patient, and was expressed in our conversations with the patient, expressed in the notes as we directed other members of the care team, we're going to do this next, and can you help me do this next? And then in team meeting, where we would come to really truly have a meeting of the minds about what the patient really needed to could kind of achieve those goals. Where I think we still could stand improving, and where we're trying to use primary care first to push ourselves to improve further, is how do we take that, get it down on paper, and make it viewable to people who are part of the team but not part of our core team. So how do we make that viewable if a patient goes to the emergency room across town? Because sometimes, still in COVID, our own emergency room is not open to them. Or how do we make that viewable if they want to travel to see Cousin Sue in North Carolina, are going to be down there for 6 weeks? How do we make that viewable to the home care team that doesn't come to our team meeting but needs to know that that's important? So how do we make that viewable, visible across time and in all environments? So that's what we're working on building now as part of Primary Care First. And we're trying to keep it simple to start. How can we take the top two patient goals, one medical and one social, express that in simple words and put that out there so that everyone can see it? So that's where we're starting. And luckily, we work in a great health system with a relatively sophisticated electronic health record. And there is already in there a template where that one secret field will automatically upload to our Health Information Exchange, or CRISP, in Maryland and DC. So that's the document that we're going to have, and that's the document that's going to show up as a structured environment in the HIE. And if I could add on to that, I'll say that really, I think in COVID particularly, but just in the last 2 years in general, all our community partners are really starting to have access to and really use that HIE. I've had multiple conversations in the last few weeks where, for instance, I might be taking care of a patient that's not a house call patient, but a community partner's patient. And they say, oh yeah, I've been following your notes in CRISP. And 3 years ago, that never happened. I think community partners are really starting to see the power of that HIE.
It's very exciting to hear the feedback that people are actually following and seeing the information out there. It's got to be rewarding for you, but as a consumer of health myself, I find that very comforting that activity is going on.
Absolutely. I mean, a care plan's useless unless it's what the patient and family members need and want, right? I think by training, the geriatricians are skilled and useful at doing that. Our physicians in particular have trained both in internal medicine and family medicine. We have some of each. So we've really tried to flesh out that question that I think Medicare was very thoughtful about in the annual wellness visit, that primary question, how is your health and what do you want? Those are two questions that we actually ask at the first visit. And I would like to give a little credit to our team. We don't just ask the question and check the box. I think all of us use that question as the jumping off point to exactly what you say. So how is your health now, and what's important to you as we build a plan together, I think are the two general questions that we ask every new patient. If I could be self-critical a little bit, physicians always imagine we're good at this stuff, but the truth is we're not that good at this stuff. We still reflexively think about adjusting the diuretic as opposed to what was going on that your family had to order takeout fast food last night? That gets to a lot of deep questions. We are not good at thinking about that. But what I will say, and credit to our social workers, when you have integrated social worker at your team meeting each week, empowered to step in and be a full part of that medical team, those questions do get answered, and then the physicians learn to ask those questions. The point is they're equal to the rest of the team, and that goes for our frontline coordinators as well, that we're having team meeting and Dr. Bruce is droning on about the diuretics. The coordinator will just interrupt and say, but did you know that their pharmacy was closed on Sunday when you sent that order? And everyone on the team being kind of empowered to step in and say that is really what makes patient care work. So to me, the care plan is that living interaction that goes on in the team, but that does literally go on in a room. And if we can't share that with the wider environment, it may not be serving the patient if they go somewhere else. So that's kind of the step that we're trying to use PCF to improve us on.
You've shared so much. There's so much here to think about. I'm thinking a little bit about our listeners and the variety of practices that are in primary care first. And if you could boil down to maybe a 1, 2, 3, a 3 next steps for someone who maybe doesn't have the same model, but would like to dip their toe in the water and try some home visits for all of the reasons, all of the value that you've expressed in meeting patients where they are and in their environment. What are maybe 3 things that they could do to start to test that out as a flexible care option?
I think the first is you just got to try it. It's really hard to come up with a list, a program, a recipe of every single thing you need in the home until you've done a couple yourself. So one is just get out there and try it. If you have a particular patient or a particular opportunity where you just know being able to quickly see them after the hospital or on your way to work, if you live in a community where that's possible, just do the first one and you'll figure out quickly what you need thereafter. Second, it's not everyone has the luxury of the model that we have, but if you can find a way to tap into social work resources, you've heard me say here that I think it's important to have social work in the room. If you can find just that one person who'll return your phone call and start working with them, you might be surprised what you can use to your advantage in community-based social work to really get involved with. Many social workers, as Gretchen was alluding to, feel kind of like they're lone wolves out there in the community, not integrated at all. And if you can build that one relationship and you return their phone calls, I promise you that'll be someone that you can then tap into as a resource later. Just get on, if you return the phone call or you reach out to them and acknowledge their usefulness, that's really another top 2. And then the third thing I'll say is the thing I alluded to in team meeting. I think probably a lot of people involved in PCF are probably already good at this, but if you haven't, really think about how to empower your frontline people to be your eyes and ears. If you haven't done that already, sit down and talk to your front office staff about how important those little throwaway comments that they hear or those little tone of voice things, getting to know the patients from a real empathy standpoint, and use that front office staff as your eyes and ears, not just as your scheduler.
Wonderful advice. Wonderful advice. I'm going to leave you with one question, and that is, I have just heard your passion throughout all of this, but as you look down the road, what's the number one goal that you have? How do you see home visits evolving?
Oh, I have so many goals and wishes. I'm going to say 2. As a systems goal, I think it's the dream of everybody who works in our practice to imagine house calls to be what I call routine, not exotic, available in communities everywhere to patients who need it, and not to be the sort of niche one-off that people have never heard of. A lot of the work that we do, part of the reason that we participate in PCF is to try and build a sustainable financial and medical model that could be replicated and done by people everywhere, because it's not going to serve large numbers of patients. It's just this kind of niche one-off grant-supported dependent practice. I really would like house calls to be routinely available to patients where they need it across the country. So that's my big picture wish. I mean, I've got some small technical wishes. One thing that would make things more viable and approachable and easier is an integrated EHR with a routing system and a scheduling system. So technology is kind of never the most important thing, but it can be so helpful to kind of get barriers out of the way. I mean, in a really dream sophisticated environment, we'd be able to bring in vital signs that patients are doing at home, bring in some information from house calls, bring in some geographic information where I know where my patients are, bring in some information about where my team members are in the field right now, and get things done in real time. But the reason I mention it is because kind of the integration and the efficiencies and using people's and information does really feed into the sustainability model, and financial sustainability is what might actually help more practices do house calls. And at the end of the day, that's what I really want to see in the future.
Gretchen, Dr. Bruce, it's been an absolute pleasure to visit with you today, to learn more about what you're doing. Thank you for the very important work that you're doing, and thank you for sharing your experience with all of us today.
Thanks so much. It's been a pleasure.
Dr. Bruce and Gretchen had so many rich stories and tangible steps to share. Hopefully this podcast left you wanting to know more. If that's the case, stay tuned for our next Practice Network Spotlight. In the upcoming Spotlight, Gretchen will share practical tips and tools for integrating social work with primary care delivery. Keep an eye out on PCF Connect and in the PCF Digest for more information on the next Practice Network Spotlight. Thanks so much for listening in today.
Want to learn more about today's guests? Find them on PCF Connect and see what your colleagues are saying about today's episode. If you have an idea for a future episode of the Primary Care First Experience, let us know by posting your ideas and comments on PCF Connect. We're here to help you make connections and learn from each other. Thanks for tuning in to the Primary Care First Experience.